This morning. So my name is Kruger, and I'm with Shriners Hospital for Children in Chicago and Marquette University. And my co-moderator for this session is Jeff Eggleston from University of Texas at El Paso. Erin Mannen is actually our third co-organizer of the session, but she was unfortunately or fortunately double booked for the award session. So we'd like to congratulate her, but also wish she could be here too. So for the session today, we've got 12 talks organized into 3 blocks. So after 4 speakers, we'll do a 10-minute Q&A, but please use the chat feature as the speakers are talking as questions come up in the session. So to kick things off, our first speaker is Tishya Wren with her talk, Tibial Bone Structural Properties in Ambulatory Children with Cerebral Palsy.
You. Cerebral palsy is the most common motor disability originating in childhood, and fractures are common in both children and adults with CP, including in the lower extremity long bones, which are not a common site of fracture in typically developing children. It's been shown previously that non-ambulatory children and those requiring assistance to walk have low bone properties, but previous research did not compare the most functional children with CP to typical development. Therefore, the purpose of this study was to examine tibial bone deficits in children with different severities of CP, including the most functional independently ambulatory children. The study subjects were children ages 6 to 16 years old, 33 with cerebral palsy, and 177 controls. For CP, the severity is characterized by Gross Motor Function Classification System, or GMFCS level. Level 1 is independent on all surfaces. Level 2 is independently ambulatory, but with difficulty on uneven terrain, such as stairs. And GMFCS level 3 is ambulatory, but using assistive devices, usually a walker or crutches. In this study, most of the patients were in GMFCS levels 1 and 2, with a smaller number in GMFCS 3. To assess the bone, we conducted computed tomography imaging of the tibias, and in this study, we looked at a slice at the mid-shaft at 50% of bone length, the proximal metaphysis at 13% of bone length, and the distal metaphysis at 90% of bone length. At the mid-shaft, we looked at geometric properties primarily, including cross-sectional area, cortical bone area, cortical thickness, and moments of inertia. In the metaphyses, we looked at cancellous density, cross-sectional area, and a density-weighted area, which is a surrogate for bone mass. These bone properties were compared among the different groups, meaning the different GMFCS levels and the controls. We used linear mixed models with sex and age as covariates. These are the results for the diaphysis. The black line with the gray shaded region is the mean and the 95% confidence interval of controls. And you can see for this graph, for the polar moment of inertia, most of the points are below that line, meaning that the bone properties are lower than would be expected during typical development. And we found similar results for all of the geometric properties, where they were all lower in all of the CP groups compared with the controls. And this included cortical bone area, cross-sectional area, cortical thickness, and all of the moments of inertia. In the proximal metaphysis, we also found low bone properties in all of the CP groups compared with controls. The density weighted area was lower for all of the CP groups, and this was primarily due to smaller cross-sectional area in all GMFCS levels. And in GMFCS 2 and 3, there was also a decreased cancellous bone density. It was a little bit different in the distal metaphysis, where only the GMFCS 3 had a lower density weighted cross-sectional area than the controls. And this was primarily due to a low cancellous density. In GMFCS levels 1 and 2, there was a large variability in the density weighted area, but not systematically higher or lower than normal. And there did tend to be lower cancellous density, but this was offset by a slightly larger cross-sectional area. So in conclusion, We did find low bone properties in ambulatory children with cerebral palsy, and we found this even in the most functional children at GMFCS levels 1 and 2. As expected, we still found the greatest deficits in GMFCS level 3. The clinical implications are that these low bone properties may contribute to an increased fracture risk, even in the most functional children, and this may help to explain why we see these lower extremity long bone fractures in this patient population when they don't typically occur in typically developing children. Thank you.
Thanks for your talk, Tishya. Our next talk will be from Marley Castleberry with the talk, The Relationship Between Dynamic Postural Instability and Physical Activity in Children with Cerebral Palsy.
Hang on just a minute. Good morning, my name is Marley Castleberry. I'm an undergraduate student at the University of Georgia, and today I'll be presenting to you the relationship between dynamic postural instability and physical activity in children with cerebral palsy. Cerebral palsy is a neurological condition caused by a brain lesion. It is associated with musculoskeletal deficits, which can lead to postural instability. Previous studies have suggested that static postural instability is negatively associated with physical activity. However, the relationship between dynamic postural control and physical activity has not been evaluated in children with cerebral palsy. Therefore, the specific aim of this study was to assess dynamic postural instability between children with cerebral palsy and typically developing children, and also to determine if dynamic postural instability during gait is related to physical activity levels in children with cerebral palsy. Our hypothesis is that children with cerebral palsy will have greater dynamic postural instability than typically developing children. For our study, we recruited 18 ambulatory children with cerebral palsy and 10 typically developing children. Their anthropometric data can be found in the table to the right. To measure physical activity, the participants were instructed to wear 2 accelerometer-based physical activity monitors for 4 days on the lateral aspect of their ankle. For typically developing children, the monitors were worn on their non-dominant limb, whereas with children with cerebral palsy, the monitors were worn on their most affected limb. To measure dynamic postural control, 3 successful gait trials, or participants completed 3 successful gait trials across 4 forced platforms. A successful gait trial was considered when the foot stepped on the forced platform completely. Center of pressure measurements, including sway velocity and distance, were calculated during these phases of gait: initial contact, mid-stance, and terminal stance, with initial contact being the phase of gait that occurs when one limb makes contact with the ground after swinging to initiate a phase of double support. Mid-stance is where one limb is in contact with the ground while the other is beginning swing phase. And terminal stance is where one limb is in contact with the ground while the other limb is finishing swing phase, preparing to make contact with the ground. Finally, the average sway distance and velocity were calculated in both the anterior, posterior, and medial lateral directions. The results of this study showed that compared to typically developing children, children with cerebral palsy exhibited lower physical activity counts, greater sway distance in the medial lateral direction during terminal stance, and greater sway distance during mid-stance. For children with cerebral palsy, there is a negative correlation between physical activity counts and anterior-posterior sway velocity. Figure 3 shows the significant relationships between physical activity and anterior-posterior sway velocity, with graph A and B showing the relationship in mid-stance. Figure A shows the relationship between physical activity and anterior-posterior sway velocity on the more affected limb, and be the least affected limb. Figure C shows the relationship between physical activity and anterior-posterior sway velocity on the least affected limb during terminal stance. In conclusion, children with cerebral palsy have a lower physical activity, which is related to their dynamic instability during the mid-stance and terminal stance of gait. During both mid-stance and terminal stance, only one limb is making contact with the ground while the other is in swing phase. This may provide reasoning as to why we see these relationships with physical activity during these phases as opposed to initial contact. Also, the lower physical activity and dynamic instability in children with cerebral palsy may be linked to their higher risk of falls. Similar to previous research that reported lower physical activity counts compared to their typically developing peers, the results of this study also reported significant lower physical activity counts in children with cerebral palsy. Previous studies have attributed this finding to deficits in balance, limitations in functional ability, and fear of falling. The results of this study further suggest that deficits in balance measured through dynamic postural control may attribute to the lower physical activity counts observed in children with cerebral palsy. Improvements in dynamic postural control may reduce this risk and improve overall levels of physical activity. We want to thank the participants and their families for the support in this study, and also the National Institutes of Health and the UGA Center for Undergraduate Research Opportunities.
Thanks, Marley. Our next talk will be from Mahdokht Ezati with her talk, Child Gait Prediction Using Musculoskeletal and Neuromuscular Models, Investigation of Different Cost Functions. If you're talking, you're muted.
Hello, can you hear me?
Yep, we can hear you now.
Okay, great. Okay, hello everyone. My name is Mahdokht. I am a postdoc fellow in System Design Engineering Department at University of Waterloo in Canada. Today, I would like to talk about child gait prediction. Professor John McPhee and I proposed a novel and very simple approach to develop child gait prediction. As you may know, we need child gait predictive simulation since it can benefit wearable robotic system design, orthosis design and tuning, aesthetic training, and rehabilitation. However, to the best of our knowledge, there are very few papers in the literature on predictive dynamic simulations of pediatric gait. In addition, most of the recent predictive gait simulations have used anatomically detailed muscle models that are challenging to fit to a specific subject. These two motivations inspired us to do this project. So we developed a 2D 11 degree of freedom child model. And for the contact model, we use 3D ellipsoidal volumetric foot ground contact model. And for the muscle model, we used muscle torque generators that are much simpler than anatomically detailed muscle models, so they can fit to a specific subject more easily. Although muscle torque generators are much simpler than anatomically detailed muscle models, however, we proposed a method using that we could generate muscle excitation and cost of transport using muscle torque generators. And to develop this method, we took advantage of two main concepts, muscle synergies and virtual work principle. And in order to develop the predictive gait simulation for children, we used optimal control and we fully predict child natural gait without tracking the experimental data. So we could predict muscle excitations, cost of transport, joint angles, joint torques, and ground reaction forces for child natural gait without tracking the experimental data. To develop this predictive simulation, we investigated different types of cost functions, and we figured out the best cost function that can predict accurately must be a combination of dynamic-based cost terms, stability-based cost terms, and human criteria-based cost terms. In dynamic-based customs, we minimized the joint jerks and we solved the dynamics equations implicitly. In stability-based customs, we controlled the position and orientation of the upper extremities. And in the human criteria-based customs, we minimized muscle activations and metabolic energy consumption. In this slide, you can see the results from this predictive gait simulation. Here you can see the fully predictive motion using this proposed method. And on top of the slide, you can see the fully predicted joint torques. The blue curves are the predicted torques and the gray areas are the experimental torques. And here you can see the fully predicted ground reaction forces and fully predicted muscle excitations. So we could propose a simplified but accurate and computationally efficient neuromusculoskeletal model for children without tracking the experimental data. And as the results show, this predictive gait simulation is dynamically consistent and physically realistic, although we track no experimental data. So we can claim that this proposed approach can be useful to predict a virtual exercise or treatment for a virtual athlete or patient under a novel condition. So this proposed method can increase objectivity in exercise and treatment planning, explore cause and effect relationships, and identify sensitive parameters. Thanks for watching. If you have any questions or suggestion, please visit us at room S3 Aristotle, or you can email me. Yeah, thank you.
All right, thanks so much for your talk. I just want to remind everyone, if you have questions that come up, feel free to put them in the chat. And after our next talk, we'll take a Q&A break. So the final talk of this block will be Safir Siddiqui giving the talk, The Unexplored Milestone, Kinematics and Muscle Utilization of How Babies Roll.
Hi, can everyone hear me?
Yep.
All right. Thank you, moderators. Thank you to the ASB Organizing Committee and my co-authors for their contribution to this study. Today, I'll talk to you about how babies roll. Well, first of all, every year we try to be the cutest talk at ASB, and I think we're still doing all right on that front. Rolling is a whole body, goal-oriented movement that takes babies from a supine to prone position, or vice versa. It is a key motor skill and an important developmental milestone that allows babies to interact with their outside environments in daily life. Now, most of the focus in the field of biomechanics has been on adults. As a former baby myself, this is unacceptable. Very little knowledge exists about infant biomechanics, and even less about how babies achieve a roll. Understanding how babies roll can help us understand a key stage in healthy infant development and ensure that baby gear is designed with infants' immediate and long-term safety in mind. Prior literature so far has focused on infant rolling primarily through the lens of forensic reconstruction of injury. Now, the only study relating infant rolling to movement and coordination is a paper by Kobayashi et al., who studied 101 infants between 5 and 10 months old and identified 6 different coordinated movements shown in the picture that babies may use to achieve a roll based on the nature and timing of movements of the contralateral and ipsilateral limbs in relation to the direction of the roll. However, that study did not explore how these coordinated movements are related to muscle activation, and here we are. Our purpose was to develop a quantifiable method to characterize muscle activation and the coordinated movements of infants rolling. 21 healthy infants with an average age of 6.7 months participated in our ongoing IRB-approved study. Infants lay flat on a playmat on their back for 5 minutes or until they achieved a roll. Surface EMG recorded muscle activity bilaterally from the abs, quads, hamstrings, and glute max, while marker-based motion capture recorded kinematics. A GoPro captured HD video, and a pulse oximeter monitored SpO2 levels to ensure safety during data collection. We calculated a mean filtered EMG for a total of 57 half rolls, and the range of motion of Eulerian and rotational angles between the trunk and pelvis were calculated for 8 of those 57 half rolls, and our labeling is still ongoing. We present data today from rolling categories that we assessed visually from video data that had at least 5 half rolls each, so the first 3 categories shown. For the first roll category, the ipsilateral arm is stationary while all the other limbs move synchronously. Now from here on forward, the first graph will be the trunk pelvis rotational angle ranges of motion, and the second graph will be the EMG activity of the contralateral side, expressed as a percentage of the ipsilateral side, with the ipsilateral side at 100%, as shown by the black line. Now I will mention, since the data analysis is still ongoing, these graphs are bar graphs, but eventually we will depict these as violin plots to better represent the spread of the data. So for this roll category, the crossbody ipsilateral arm movement and pelvic tuck movements are supported by the high trunk pelvis range of motion in all rotational directions, the higher contralateral ab, quad, glute max EMG, and the higher ipsilateral hamstring EMG. For the second roll category, all limbs are moving synchronously, so most of the range of motion is in trunk pelvis flexion, and we see similar EMG activity to the previous roll category since the lower body coordinated movements are similar. Now for the third and final roll category, it involves the ipsilateral arm stationary with the ipsilateral leg and contralateral arm moving synchronously and the contralateral leg then following. The trunk pelvis range of motion is similar to the last roll, with the most range of motion in trunk pelvis flexion extension. However, all contralateral EMG activity was found to be higher, and that doesn't necessarily make sense yet. Overall, we found a promising approach to quantify the coordinated movements of infant rolls using a combination of video, motion capture, and EMG. And in the near future, we're excited to explore time series EMG data as it relates to events within the roll, the relationship between the stages of infant development and the prominent rolling categories observed, the contribution of the head to initiating and completing rolls, and using video-based methods to assess infant rolls in at-home settings. Our current and future findings may help us understand how babies achieve a roll, which in turn can provide crucial insight in situations when motor skills and developmental milestones like rolling are not being achieved. Now, from a product safety perspective, we can gain valuable insight into whether it is easier or harder for infants to roll over in certain infant products that are marketed as sleeping products, and how that relates to accidental suffocation scenarios. Thank you. Please feel free to ask me questions during the live synchronous QA or reach out through Twitter or email.
All right, thanks so much to all the speakers for their talks. Looks like we got about 7 minutes for Q&A, so please feel free to put any in the chat while they come up. While people are starting, Tishya, I know you didn't talk about activity levels in your talk at all, but I'm just curious if you happen to have any data or had thought about looking at the activity levels within your GMFCS level group, and if that had any effect or could potentially have any impact on the bone properties within each of the groups.
Yeah, we are collecting activity monitor data. We haven't analyzed it all yet, but there have been quite a few previous studies, using especially a stepwatch activity monitor. And, they do find reduced activity levels in CP, which, as you might expect, decreases more the more severely affected they are. Our current thought is that in terms of the bone, for the less functional children who have a lower number of steps per day, that the number of steps, will be a mechanical stimulus affecting bone mass. But once you get to the most functional children who have, a relatively higher number of repetitions of loading, that it will be the magnitude of the loading that's more important for those. But we haven't established that yet.
Right, and it looks like we have a question for Marley. How much is activity reduced in the children with cerebral palsy?
Roughly 40%.
Oh, wow, okay. And it looks like we have another question for you, Marley. What is the prediction accuracy? Have you done a correlation analysis between predicted and measured trajectories?
I think this question is for me.
Oh, yes, that would actually probably be correct.
Yeah.
Yeah, do you want me to answer it?
Yes, please.
Yeah, actually, we calculated root mean square errors for the predicted results, and for the muscle excitation, the root mean square error is 0.06, and for the joint torque is 10 Newton meters, and for the normal reaction force is 40 Newton meters, and for the tangential reaction force is 10 Newton. And for the joint angles, the average root mean square error is 5 degrees. And about the second question, which is the correlation analysis between predicted and measured trajectories, we didn't do that, but that's a good idea. We will consider it in our next step. Yeah, thank you for your question, Jerry.
And then one more question for you, Mahdokht. Can you also model children with disability? How would you incorporate weakness or spasticity?
Yeah, actually, that's a good question. Based on the method we proposed, we said that, we can ignore the anatomically detailed muscle model, and we can use muscle torque generators. And based on the cost functions I said, you should only dynamic equations, dynamic-based cost functions, stability-based cost terms, and also the human criteria-based cost terms. If we want to model disabilities, we have to consider one extra cost term in the human criteria cost terms in order to model that. For example, we can calculate the muscle efforts or also add extra terms to that. But the novelty of this work is that we do not need the experimental data. And after that, we only need experimental data to compare the results. Yeah, I believe that if we can consider a cost term, we can use this method to model disabilities as well.
Awesome, thank you. Sophia, I've got a quick question for you. How does EMG prep differ on babies than it does on non-babies?
Well, no shaving to start, which is great. But beyond that, I will take it a little bit further. One of the other things is most of our EMG data, these are gross muscular groups, just because of their size, we can't be super accurate on where the muscle is. So, which is why we target larger muscle groups that we can actually place the sensors over.
So do you think that the amount of fat that babies have changes or modifies that signal at all?
I think it definitely does, especially because of surface EMG. Obviously, IRB would have a field day if I wanted to do fine wire EMG on babies. So that's not happening anytime soon. But yes, definitely, I think that has a contribution. We don't know how to quantify that part yet. And okay. To answer Dr. Wren's question, yes, the babies do try to pull equipment off, which is why we wrap them in Coflex. But markers are fair game. Well, it's not so much they try to pull it off, it's more so that they try to eat it, which is, I guess, the bigger problem.
And it looks like another question for you, Sophia. Do you know which of the three patterns was firstly initiated or preferred? Have you seen evolution among three patterns?
That's a great question. So I can't specifically answer for our study yet since it's still ongoing, but I can speak about the study that we cited, that the Kobayashi paper. Generally, it has been observed, and we've seen this visually, that older children will use less stationary limbs, but then there comes an interesting trade-off, and it comes through base of support. So when we think of base of support in traditional terms, wider support is more stable, narrower is less stable. But it is kind of flipped when you talk about rolling. Older infants will use a narrower base of support actually to initiate that roll, because the more unstable you get, the faster you can roll. And so, it's pretty interesting. And yes, we are considering markerless very strongly, just because with so many sensors on the body, we believe that has an effect on their natural movement.
Awesome, thank you. So that'll be the last question we take for this bunch of talks. Now we're going to move into the second block. And first off for this group is Hunter Bennett. with his talk titled "Are Gait Biomechanics Related to Physical Activity Engagement? An Examination of Adolescents with ASD."
All right. I didn't get the normal green around it. Does it show my screen?
Yes, we do.
Cool.
We are looking at the PowerPoint.
Thanks. All right, so first I'd like to thank my co-authors, Drs. Ringlev, Bobzien, and Hagel, as well as our funders, Jeffers Trust Awards and Interdisciplinary Research. So youth with autism spectrum disorder, much like their neurotypical peers, are generally physically inactive, spending more time in front of screens and et cetera, and not meeting our daily guidelines for being physically active. There are a myriad of different barriers that exist for these individuals and across all populations, but some of which have been dealt a little bit deeper within the current literature for persons with a disability. And most of these stem from a socio-demographic nature. So what's the self-motivation or the beliefs of their parents, and how's that disseminated to the children on being physically active? And probably most importantly, access to adequate places to go, as well as personnel who are well trained to work with these individuals to be physically active. Something that's not been really investigated is the possible physiological barriers to being physically active, especially for those with ASD. So the literature has clearly shown that those with ASD demonstrate some motor control issues, balance issues. They typically choose to walk with slower speeds, shorter strides, greater step widths, all of which could negatively impact their efficiency and may be a deterrent for being physically active in that nature. And that's really where our research stems, is trying to determine whether or not some of these gait mechanics are significant predictors for physical activity levels in this population. We recruited 25 youth with ASD between the ages of 13 and 18 and had them perform 2 different types of testing. First was on site in our neuromechanics lab. We performed traditional gait biomechanics testing, where we calculated their joint powers and their joint works, both positive and negative. Then we took the sum of the absolute values for each one of those joint works and took it across the entire body to give us total mechanical work. So some measure of the effort level for them to walk, as well as their speeds when walking at self-selected speeds and their stride lengths. The second part of their testing involved wearing a triaxial accelerometer on their waist for 7 consecutive days after the mechanics testing. We then used these data to determine their average daily amount of physical activity in minutes, as well as their moderate to vigorous physical activity in minutes. The goal was to determine whether or not these gait mechanics are significant predictors of physical activity, so we used linear regressions. What we found was that work was not a significant predictor of time spent in moderate to vigorous physical activity, whereas stride length and speed are significant factors, stride length being a pretty strong predictor, whereas speed was also significant, but somewhat less. For total PA, again, work was not a significant predictor of total time spent being physically active, whereas stride length and speed were significant predictors of it. Both of these variables being important, as we've seen in the literature, that across persons with a visual impairment, persons who are more prone to falls, and even healthy individuals who are more physically active or more able to be physically active typically choose to walk with longer stride lengths and at faster speeds. So what do our findings mean for us? Well, first off is that we did see some of the aberrant gait mechanics have been reported throughout the literature. So on the left is an individual walking with more of a stooped trunk. On the right is an individual that actually walked with her arms completely out, as if she was tightrope walking. And these kind of aberrant gait mechanics certainly would be increasing their mechanical work and decreasing their efficiency to walk. But overall, it doesn't appear to be a significant barrier or limitation to being physically active for this population. So in essence, it's kind of a good thing that we didn't find that significant relationship there. But what the other items do tell us, at least from the stride length and walking speed aspects, are that These are easily modifiable factors that may improve their capabilities and improve their efficiencies that they walk with. And some of that may stem just from their familiarization or comfort levels with their surroundings, with their environments. So overall, moving forwards with research, we need to consider holistic approaches in determining this from multiple factors. Thanks.
All right, thank you, Hunter. Next up on the list is Alyssa Olivas with the talk titled Super Newtonian Strategies Adopted by Children with Autism Spectrum Disorder.
Okay, hello everyone. My name is Alyssa Olivas and I am a PhD candidate from the University of Texas at El Paso. So today I'm going to be talking about strategies, and a strategy is considered a neuromuscular solution for the performance of a motor task. And this is usually unique for individuals depending on their experience and their independent morphologies. Today I'm going to be focusing a little bit more on load accommodation strategies, which are responses to an external stressor, such as an external mass, while performing a movement. And we can see this figure that was created by James et al. In 2014 that shows the different types of neuromuscular strategies. The one that I am going to be focusing on today is this Newtonian strategy. So we can see that as an applied stressor is applied to someone as they are performing a movement, and it increases, the external reaction force or the ground reaction force actually increases by an equal magnitude and an equal rate. So it's a perfectly linear relationship. Now, a lot of these strategy studies have focused on healthy individuals. Today, I'm going to be focusing on children with autism spectrum disorder, which is typically regarded as a behavioral disorder that can be treated with an intervention such as a weighted vest. Now, the weighted vest has had, there's been evidence to show that it helps with behavioral symptoms such as decreasing hyperreactivity and decreasing sensory defensiveness. But autism is actually there's more research and evidence that autism is becoming a movement disorder and has implications for gait and motor impairments. So a weighted vest has actually been shown to increase gait smoothness. So if this is an intervention that they typically use, then this would also be a suitable intervention to look at to see how it impacts the load accommodation strategies that this population may be using. So that leads to the purpose of the project today, which is to evaluate group load accommodation strategies by looking at the vertical ground reaction force while walking with a weighted vest in children with autism and comparing that to neurotypical children, and to also evaluate individual strategies, since strategies can be looked at on a more individualized basis. For the study, I had 7 children with autism and 5 age and sex matched neurotypical children that participated. They walked without a weighted vest, and then they walked with the weighted vest that had 5% body mass distributed evenly, anteriorly and posteriorly. And as they walked, force data was obtained with 3 AMTI force plates. Now, after the vertical ground reaction force was normalized to body mass, we can take a look here and look at our autism group and the neurotypical group, how their vertical ground reaction force differed from just normal overground walking to then walking with the weighted vest. And we can also see the % change in vertical GRF. So there was no statistically significant interaction between the effects of the group and the condition. There was no group main effect or a condition main effect, but we can see from the % change that was obtained here that both groups actually displayed an average super Newtonian response to the load. And we can actually take a look at that a little bit better in these graphs. So if we're looking at a Newtonian response, we have these blue lines here. So if the mass increased by 5% body mass, then the % change in vertical GRF should also increase by that 5%. Now, the autism group was a little closer to 10% change in vertical ground reaction force, and the neurotypical group was a little closer to 7%. And then the gray lines actually represent the individuals themselves and how they responded. So a lot of them responded also with the super Newtonian response, meaning that the percent change was greater than that 5%. In the ASD group, there was one that exhibited a positive biomechanical response, meaning that they did increase their vertical GRF, but just not as much as the 5%. And then in the neurotypical group, there was actually one who demonstrated a negative biomechanical response. So even after they were loaded with the external mass, their percent change in vertical ground reaction force decreased. So we can see here that even though both groups demonstrated the super Newtonian response, it means that it was a neuromuscular strategy because their percent change in vertical GRF increased more than the percent body mass that was in the vest. And this is important because there's not really a lot of research that examines the effects of these external stressors as a children with autism is walking. And it's also important to note how they compare to their neurotypical peers. And here we can see that they both adopted a similar strategy. Of course, more participants would be needed to confirm this, but it seems that they are adopting a similar strategy. And this is important because this may be a common intervention that children with autism use. So if it impacts their motor control or their gait in any way, it's important to identify those differences. Thank you all for your attention today.
Thank you very much, Alyssa. Next up, we have Matthew Bierce with the talk titled Effect of Walking Speed on Gait Stability and Joint Kinematics in Children with and Without Down Syndrome.
Sorry about that. Can you see and hear me?
Yes.
Great, thanks. So for this talk, talking about effects of walking speed on gait stability and joint kinematics in children with and without Down syndrome, I'd like to first thank my co-authors for their contribution to this work. Down syndrome is a common genetic condition that results in many functional and structural deviations, most notably hypotonia, hyperflexibility, low muscle strength, reduced cerebellar function. And this can lead to a characteristic gait pattern that kind of seeks stability, so reduced stride length, increased step width, reduced preferred walking speed. However, in the literature, there's been shown to be improvements when these individuals are challenged to walk faster than their preferred speed. So our main questions were kind of twofold. First, we wanted to look at what the effects of speed were on their lower joint kinematics, so looking at their gait strategy, as well as evaluating a measure of dynamic gait stability as margin of stability to really kind of get a little bit more of an idea of this gait pattern that kind of seeks stability. So we compared 12 children with and without Down syndrome. They completed overground walking trials at two different conditions, normal speed, which was just a self-selected preferred walking speed, and then a fast walking speed, which was instructed as walking as fast as possible without running. And the variables that we looked at here will be sagittal plane joint angles of the ankle, knee, and hip, and then margin of stability at two different gait events, so just before heel strike, as well as at mid-swing. And we were looking at these in two different directions, in the anterior, posterior, and the medial lateral direction. So on the right, a quick schematic kind of showing how these variables we presented. A large anterior posterior MOS would mean that the center of mass is being projected further anterior of the edge of the base of support, which would be the toe marker of the trail leg. And for the medial lateral, the center of mass is being projected further medially of the outer edge of the base of support, or the lateral ankle marker. So we'll look first at the joint kinematics. So these are the results from statistical parametric mapping, comparing these time series. And the left-hand column is speed effects for each group separately. The middle column is group effects for each speed condition. And then the right-hand side are the statistical results. So what we found for the ankle was an interaction between group and speed, and this can be seen quite evidently here, where the children with Down syndrome increased dorsiflexion during stance phase when walking faster, which led to a group difference at this condition. For the knee, somewhat of a similar story. We still see a group by speed interaction, and really throughout the gait cycle, children with Down syndrome walked with a greater flexed knee through stance and swing when walking faster, which led to kind of a group difference there as well. For the hip, again, a group interaction here, group by speed interaction, where children with Down syndrome, once again, increased flexion of the hip kind of early in stance and late in swing when walking faster than preferred. For the margin of stability, again, we looked at this in anterior posterior, which is the top row, as well as the medial lateral direction, which is the bottom row, at two different gait events, so just before heel strike and at mid swing. Just before heel strike, the anterior posterior margin of stability was less in the children with Down syndrome when they self-selected their walking speed. However, this group difference disappeared when challenged to walk faster, as both groups increased this margin of stability in the anterior posterior direction at really both gait events. For the medial lateral direction, regardless of walking speed or event, children with Down syndrome walked with a greater medial lateral margin of stability. And then there was a slight increase in this margin of stability at mid-swing when walking faster in both groups. So to kind of summarize, the main group effect that we found was that the children with Down syndrome walked with a greater medial lateral margin of stability, regardless of condition or event that we looked at. And so this might be leading to their foot placement strategy of a wider step, kind of taken from the opposite perspective. Their wider steps are not at least minimizing potentially this medial lateral center of mass movement, because that's being factored into this margin of stability measure. And then when challenged to walk faster than preferred, children with Down syndrome walked with increased joint flexion. So maybe there's a need to strengthen extensors here so they're not adopting an atypical gait pattern. And then encouragingly, the children with Down syndrome were able to increase their margin of stability, which we can also think of kind of reducing their margin of error for a fall. We didn't observe any falls, so this is they're capable of this, and so we're interested in what the long-term training adaptations might be if they become more comfortable with this reduced margin of error. Thank you. Look forward to your questions.
Thank you very much, Matthew. And to wrap up this group, we have Samantha Schwartz next, giving the talk Longitudinal Evaluation of Wrist Joint Kinematics in Pediatric Manual Wheelchair Users.
All right, thank you. Today, I would like to start by thanking my co-authors for their help in writing this abstract and this presentation. So I'll hop right in here. As a bit of background, there are an estimated 60,000 children under the age of 21 with spinal cord injury who use manual wheelchairs. Most studies of and recommendations for manual wheelchair users with spinal cord injury, however, focus on adult populations. And it's been noted that children likely adapt differently to their manual wheelchair than adults do. So it's important to consider the differences between children and adults in training recommendations made for pediatric populations, rather than just using the recommendations made for adults. Following that, the purpose of our study was to investigate changes in wrist kinematics over time in pediatric manual wheelchair users. Changes in these parameters may indicate when interventions are necessary to prevent development of wrist pain or pathology in pediatric populations. We had 6 pediatric manual wheelchair users with spinal cord injury who participated in the study. They came for 2 visits, approximately 1 year apart. There we obtained height, weight, and anthropometric measurements, as well as some demographics listed in the table below. You can see here that we have a wide range of ages for our participants, which makes it kind of interesting to see how things change by age as well as over time. We placed 27 passive markers on the participants and collected trials of them propelling along a 15-meter walkway at a self-selected speed and self-selected stroke pattern using Vicon software. The data were then processed in Vicon Nexus and run through our custom MATLAB inverse dynamics model to calculate wrist joint angles of the dominant hand, which was the right hand for all participants. The figure to the right here shows the wrist peak sagittal plane motions. So we have the flexion as the positive direction and extension as the negative direction here. The black dots represent the maximum values of either flexion or extension averaged for each participant at each visit. The gray dotted lines connecting the top and bottom here represent the range of motion for that participant at that visit. And then the solid black lines connecting the two dots here represent the change between visits for each participant. So following that, we can see that the three eldest participants showed relatively large increases in the sagittal plane range of motion. And it has been noted previously that wrist extension greater than 33 degrees can lead to pressure in the carpal tunnel beyond a critical pressure threshold that has been related to carpal tunnel syndrome. We found that all of our participants exceeded this value at their first visit, and only 4 exceeded this value at their second visit. Here we have a similar figure with the dots representing this time radial deviation or ulnar deviation, because we are now looking at the coronal plane. Here we can see that the 3 eldest participants showed relatively large increases in their coronal plane range of motion, while the youngest 3 did not. And similar to the sagittal plane, peak wrist ulnar deviation greater than 14.5 degrees has been connected to pressure in the carpal tunnel beyond a critical pressure threshold. However, none of our participants exhibited this at their first visit, yet 4 exhibited this beyond this threshold at their second visit, which could be related to a potential of developing carpal tunnel syndrome in the future. So to wrap up, we successfully quantified differences in wrist kinematics for pediatric manual wheelchair users with spinal cord injury over the time span of 1 year. And these changes may relate to the likelihood of developing wrist pain and pathology. However, further research is needed to better understand these changes, as well as their contribution to pain and pathology development in pediatric manual wheelchair users. You can contact our PI or me for any questions. Thank you.
All right, fantastic. So it looks like we have about 8 minutes for questions. It looks like we already have a few coming in the chat.
I'll try and get as many of these as we can covered. Start with from Jerry Wu. Hunter, do you know why children with ASD walk with different walking patterns? Is it primarily due to neural control or muscular weakness? Would you suggest training children with ASD for faster walking speeds to improve their physical activity?
Yeah, that's a difficult question. I think Dr. Eggleston has done some work in here to be able to answer that question as well. And so I think that it can be a little bit of both, but it depends on who you're dealing with. So, you know, there is this coined term of heterogeneity across this population. And I see that to be quite true. Kind of linking together with another question I saw here and what I showed in the video, persons choose to walk in very different profiles, and it depends on the level of support that they need and how they're affected, where they're affected. So there's certainly some control issues. Muscular weakness is difficult to say. We've done some work investigating muscle strength, but overall, they certainly have enough strength to walk. So it's more unlikely that it's a control issue.
Cool. Next, we'll go with a question from Emily Chavez. Alyssa, why was 5% body weight used in the weighted vest? Have you considered greater amounts? Great job.
Yes, so a previous study that we had worked on actually showed that 5% body mass modified spatial temporal parameters in Gait. And so that's why this was used for the strategies project, but also children with autism tend to use between 2 to 10% of their body mass in a weighted vest for the therapeutic intervention. So it is an ideal amount. We have used 10, 15, and 20% body mass in the weighted vest as well. So it would be interesting to look at the strategies, the accommodation strategies for those body masses as well. So I'll keep that in mind. Thank you.
Next question is from Tishya Wren. Samantha, how long after injury was the first assessment? Were they experienced or new wheelchair users?
Great question, because like it's very interesting to think about. So checking back at our demographics, 2 of our 6 participants were fairly new wheelchair users. However, everybody else had been using their wheelchair for at least a year. Interestingly, subjects 4 and 5, which were 2 of our elder participants, were the 2 newer users.
Got a question for Matthew. I'm thinking about how much of a speed interaction there was that you discussed. Has there been any formal gait training done in this population for rehab strategies? And could maybe your results kind of start to inform some of these rehab strategies?
Yeah, I think that's the hope. As far as I'm aware, there's been one study out there in the literature that's looked at treadmill training. That's kind of a novel intervention for this group that has shown the benefits that kind of we were discussing as far as the improvements of challenging the walking speed, longer stride lengths, some reduction in step width. But yeah, I think that's essentially the hope, is to try to get them out of what's comfortable, because some things will improve and they are capable of maintaining stability at those faster speeds.
Cool, thanks.
Hey, Sam, I've got a follow-up question for you. So that study that you just presented was mostly about wrist movement. Have you thought about incorporating any type of coordination between the upper arm and the hand, and maybe even kind of going back to that experience component, analyzing those as covariates or some sort of relationship?
Yeah, so we actually, with these data, we did also collect other upper extremity data. They just weren't as interesting as the wrist, so they didn't get presented here. But yeah, we definitely like to look at that stuff as well. With our large marker set, we get a lot of data to analyze. And so, yes, we love to look at all of the other upper extremities and kind of make all of those connections.
Very cool.
There's an earlier question from Chris Wendt for Hunter. Great talk, good to see you. How was the overall compliance with the off-site physical activity collection? Is it well received in the attrition rate?
Another good question, and good to see you too, Chris. So we were able to compensate our participants, which certainly helped. But I think the other thing that helped us out would be that all of them had parents involved in some capacity. And so the adherence to wearing it, we only lost one participant out of the whole group that we had that didn't actually complete that part of it. So I think those incentives really make a difference, especially when you have a multifactorial population like this that need those kind of considerations. So we also did our best to try to meet them wherever possible to get them back. So we've had some success with mailing, but we've also had some lost items in that way. So we would meet them in parking lots or wherever we need be to get this accelerometer back from them to get that data. So.
And then before we close it out, there was one more question from Jerry Wu for Hunter. Did the child that walked with their arms out do that in daily life, or did you give specific instructions to the subject for that walking task?
That's a good question. I would assume that's what she did in her daily life. Her parent didn't act like that was something that was different. And she did kind of demonstrate some of that no matter where we were walking, so with or without the marker system applied to her. We tried to be very cautious in any of the instructions that we passed along to the individuals. So we were very strict about our wording and made sure we always just said the same thing, which was walk as if you're headed to, between classes. And so we gave no other indication of what they should be doing, right, wrong, good, bad, because another thing with this population is they might be more susceptible to wanting to please you. And so if we told them, walk in such a manner, they might really try to meet your needs more than demonstrating their normal patterns. So.
Well, thanks to all the speakers on that block, and thanks to all the audience for the great questions. We'll be moving on to our last block of speakers coming up. So next, kicking off this one, we have Morgan Dahlman with her talk evaluating anthropometric scaling of a generic adult model to represent pediatric strength. If you're talking, Morgan, you're muted.
Can you guys hear me now?
Yep.
Perfect. And can you see my presentation?
Yep.
Okay. So thank you for the introduction, and I'd like to thank my co-authors for their contribution to this research. And hopefully there it goes. Okay. The structure of musculoskeletal tissue during childhood and adolescence influences the joint and tissue loading function, and understanding their relationship is critical for ensuring health of the developing musculoskeletal system. As youth participation in sports increases, so does the corresponding musculoskeletal pain and injury. Shoulder injuries in the pediatric athletes, such as physiofractures and Little Leaguer's elbow, are increased due to strength imbalance between bones and surrounding soft tissue, and often occur during developmental events. Injuries and chronic pain during childhood have an associated risk with injury and pain in adulthood. However, limited data is available on upper limb muscle architecture and joint moments of pediatric patients. Adult upper limb musculoskeletal models have been developed, and anthropometric scaling may be appropriate to create a pediatric model. Detailed work characterizing the anatomy of upper limb in adults has revealed that the distribution of muscle volume is highly correlated across healthy adults, and that muscle volume is an effective predictor of strength. Importantly, research done by M et al. Revealed that pediatric muscle volume distribution in the shoulder is consistent with that of adults. Thus, some aspects of the shoulder musculoskeletal structure may be easily scaled from adults to pediatric. Additionally, although there are changes in the upper limb length and height during growth, a significant linear correlation between height and ankle length was shown in previous research. However, limited information, like I said before, is available on pediatric population, and other factors such as muscle attachment location and coordination may affect the pediatric strength profile. So in order to assess the anthropometric scaling, we used length parameters and muscle force parameters. Length dimensions in the model were scaled using linear regression to relate forearm length and heights of 366 children and adolescents between the age of 6 and 23 years, as well as 107 of their parents between 29 and 40 years, for males and females using a previously reported data set from New et al. The mean values were used as reported for each of the 8 age groups represented by the points on the graph. All model length dimensions were scaled for a child of a given height using a length scale factor defined as the ratio of the estimated forearm length from the regression to the adult model forearm length of the model. The OpenSim scale tool was used to impose the length scaling. The OpenSim scale tool, however, does not scale the max isometric force of the muscle or actuator when it scales the length. Thus, we had to create additional linear regression between average body mass and the total shoulder muscle volume to calculate the max isometric force. The MIF, or max isometric force, was scaled using these linear regressions and applied to both males and females. The shoulder muscle volumes and weights of 11 children from a previous study by M were used, and individuals were included in the linear regression if they identified to be within the normal weight range based on body mass index. The MIF scale factor was determined by taking the average ratio of the calculated force and corresponding peak isometric force from the nominal adult model. The MIF scale factor was then applied to all 32 muscles in the upper limb. To evaluate anthropometric scaling of the adult model for pediatric shoulder strength, we used those linear regression models and an existing musculoskeletal upper limb model representing a 50th percentile male adult to scale to represent 6 children between the ages of 7 and 18, 3 male, 3 female, based on the height, weight, and sex shown in the table. Isometric shoulder moment was predicted assuming full muscle excitation. Predicted moments from the scaled model were significantly correlated based on the results shown in the table on the left. The linear regressions relating the peak predicted moments for function for the model tended to be underestimated in comparison to the measured values, with an average slope of regression value of 0.69. Shoulder abduction was most accurate with a slope closest to 1 at 1.1, and shoulder adduction was most underestimated with a slope of 0.46. Shoulder abduction was the only linear regression for joint moment that was overestimated. A key challenge of this research is the limited data describing upper limb muscle anatomy in pediatric population that inform the scaling rules. Other potential factors that could be affecting the result include variation in limb proportion, muscle attachment, muscle coordination, and muscle tendon stiffness. However, this work does provide an initial framework for pediatric upper limb models generation through anthropometric scaling. Thank you, and feel free to ask questions during the open Q&A or through email.
All right, thanks so much for your talk, Morgan. Our next speaker will be Matthew Bursey with his talk, Differences in Joint Function Between Children and Adults During Hopping at Different Frequencies.
Thank you again. Again, I'd like to thank my co-author, Dr. Jerry Wu, for his contributions on this study. So hopping is a fundamental motor skill, at least from kind of a pediatric perspective. It's been used to evaluate whole body vertical stiffness control following a spring mass model, as well as shortening cycle function. For adults, the ankle joint has been identified as very important for hopping, particularly scaling hopping to different frequencies. Ankles tends to be used as the spring, and then the stiffness of that spring kind of scales in order to change hopping frequency. However, there are some neuromechanical differences between children and adults, and so we are interested in whether these differences will result in functional differences at the point during single leg hopping. We compared 13 adults and 14 children. The age range for the children was 7 to 12 years. They completed trials of single leg hopping at 4 different conditions that were cued by a metronome and based upon their self-selected preferred frequency. We had a slower than preferred frequency, we cued their preferred frequency, and then a moderate and fast increase above their preferred. We used the joint functional index first proposed in 2016 to quantify joint function, which separates into strut, spring, motor, and damper. Where strut is moment occurring about the joint with minimal displacement, spring kind of looking for a storage and release of energy, and then motor and damper make up kind of what's left. So energy that's put into the system that's not captured by spring is the motor, and damper is energy being taken out. And so we'll look at each of the joints separately here, kind of in the same similar charts. So from left to right, the 4 bars refer to the different frequency conditions from slow to fast. So we're increasing frequency. And then we have the different indices measured or represented by the different colors. So strut, damper, spring, and motor. So for the ankle, children showed greater strut-like function than the adults. And with increasing frequency, both groups increased the strut function. Spring showed an opposing pattern, so children had less spring function than adults across the conditions. And as frequency increased, spring function decreased. Kind of another interesting thing that we can pull from this analysis is what's the primary function of the joint, which is assumed based upon the majority index at that condition. And so for the preferred frequency, we can see that both adults and children had a majority spring-like function, so they're potentially mostly using the ankle as a spring. And then as frequency increases, adults are able to maintain this primary spring-like function all the way up through the fast condition, but children switch to a strut function. So they're unable to maintain this spring-like function when increasing frequency. For the knee, kind of similar results as far as the strut and spring. Children had greater strut function across conditions. As frequency increased, strut increased. Children had less spring function than adults. As frequency increased, spring function decreased. Looking at the primary function, again, for the preferred, adults used primarily a spring-like function, while children were pretty much split. So this kind of separated based upon the individual. Some had a primary spring, some had a primary strut. which was kind of interesting. And we're trying to figure out what's kind of driving those individual differences. As frequency increased, both adults and children switched primarily to strut function at the knee. For the hip, we can see mostly strut-like function for both groups. Kind of the interesting result here is that children, kind of similar to the other joints, tended to rely more on the strut-like function at the slower than preferred condition, although it's definitely primary for both. So to summarize, there's definitely some differences in joint level function during single leg hopping. Children are unable to maintain a spring-like function when increasing faster frequencies at the ankle, greater reliance on the strut function at the knee and ankle. And then there seems to be some individual differences of being able to use the knee primarily as a spring at a self-selected preferred hopping frequency, and trying to piece apart what those differences are. And then, of course, we're interested in kind of evaluating these as reference values for children with developmental differences. Obviously, our interest in children with Down syndrome who have different stiffness capabilities and control. So thank you, and I look forward to your questions.
Thanks, Matthew. Our next talk will be by Micah Garcia. Wearable tech and electronic journals, are they consistent in adolescent runners?
All right. Well, thank you very much for that introduction. And I'd first like to start by thanking ASB for the opportunity to present today, as well as to acknowledge my co-author, Dr. Bassett Jones. So running programs are often developed to monitor external loads, such as time and distance, as well as internal loads, such as running intensity. And typically, runners will use a running journal to self-report these kind of running measures. And they can do it either with a paper or more recently, even an electronic journal. However, this reporting is going to add an extra burden to runners that they now have to complete something after their running session. With advances in technology, such as GPS-enabled watches, now running sessions can automatically get uploaded to a user profile to kind of remove some of that tracking burden placed on runners. Now, if we were to compare journals and wearable tech to each other, external loads are going to be often monitored using the same units. So time and distance will be similar. You got your minutes, you got miles or kilometers. However, internal loads are often going to be monitored with different units. So journals are going to use more of a subjective measure of intensity, such as the session rating of perceived exertion, whereas wearables are going to use more of a physiological measure of intensity, such as your heart rate. So there have been some studies in adults that looked at how accurate they were in reporting their running distance, and they did a pretty good job overall. The average difference was about 2% compared to the true distance when they self-reported. However, there was a rather large range in the reporting accuracy, and it could have been anywhere between -28 to 40% different than the true distance. GPS watches, on the other hand, appear to be a little more accurate, as the average difference from the true distance was -1.2%, with a much more narrow confidence interval of between -0.7 to -1.5%. Internal loads have also been investigated. So comparing your subjective measure, your SRPE, to training impulse, which is a physiological measure. And this was done in adolescent runners, and it was found that they were strongly related. But training impulse is going to be a rather cumbersome metric that you have to kind of put in place in the front end. And it essentially looks at the duration spent in different heart rate zones and adds them together for this quantitative measure. And so since it is a little burdensome to set up, it's not clear if there's a relationship between SRP and a single measure of heart rate, such as the average or the max heart rate. So we were interested in comparing external loads and internal loads for adolescent runners, whether they self-reported it with a journal or if it was something that we extracted from a GPS watch, to see if those measures were similar. To do this, we had 23 high school cross-country runners enrolled in our study. And during their cross-country season, we loaned them a GPS watch. So we were able to extract the time, distance, and then their average and max heart rate for each running session. But then we also asked them to self-report their running session and to tell us what their time, distance, and then their SRPE was. And SRPE was reported on a 10-point scale, where 1 was considered a very easy run and 10 was a maximal effort run. We then looked at the relationship between the self-reported measures and what we were able to pull from the watch to see if they agreed. And we did this for both external and internal loads. But then we were also interested in looking at intensity zones, because oftentimes coaches will prescribe a run according to a target heart rate zone. And so we have 5 intensity zones here, zone 1 being the lowest intensity, zone 5 being the highest intensity. And we classified their intensity according to their reported SRPE, as well as accorded to what we pulled from the watch for what their average and max heart rate were. And we looked at Cohen's cap to see if there was agreement between classification for intensity zones. So looking at our results, starting with external loads, on the x-axis is going to be the self-reported measures, and y-axis will be the watch measures. We've got our time on the left and distance on the right, and you see that both these measures have a strong relationship between the self-report and the watch measures. However, when we look at our internal loads, so we talk about SRPE on the x-axis and then heart rate on the y-axis. The left graph is going to be the average heart rate for the run, the right will be the max heart rate. And we see for both of these, there's poor relationships between them with an R value of less than or equal to 0.15. And then if we look at the agreement between the intensity zone classification based off of their SRPE or average heart rate, we found very poor agreement with the kappa value of 0.07. And then when we compared SRPE to max heart rate, we even found a lower agreement with the kappa of 0.03. So overall, we found that there were strong relationships between self-reported measures and GPS watch-derived measures for your external loads. And this isn't all that surprising because it's likely that participants would report their distance and time based off what their watch said, which probably contributes to why we saw such strong agreement. But then interestingly, there were very poor relationships and agreements for internal loads. So when we compared our subjective measure to our physiological measure. And something to consider here is SRPE, our subjective measure, is likely going to be influenced by other factors such as fatigue and sleep. So if a runner had poor sleep quality the night before a run, they might report, a higher perceived effort than if they had good sleep quality leading up to a run. And then something else that was interesting was that since oftentimes coaches will prescribe a run according to a target heart rate zone, we found that the heart rate zone classification did not align with how difficult the runners perceived it to be. So maybe it might be more appropriate to use to prescribe runs according to a perceived effort instead of based off of heart rate. So in conclusion, external loads were similar, whether they were self-reported or pulled from a watch, but it appears that subjective measures of intensity are different than a physiological measure of intensity. Thanks for your attention.
All right, thanks for your talk. And our last talk will again be Micah presenting weekly change in running loads in high school runners during a cross-country season.
Okay, thank you for that introduction again, and thank you to my co-authors for their contributions. So running programs are often going to be designed to measure external loads such as time or distance, but only relying on these external loads is going to fail to consider internal loads or the running intensity, which might vary from run to run. So for example, let's say you did 2 3-mile runs on different days, and that first run you're going to do at an easy, comfortable pace, and then the second run you're going to do it at a faster, higher intensity pace. If we just look at their external load, so distance, we would say that these runs are identical. They were both 3 miles. However, that's not going to be the case because the intensity is going to be vastly different between that easy run and that faster run. And so this is where workload comes into play, because this can be a measure that can account for the interaction between external loads and internal loads. And it can be easily calculated by taking your external load and multiplying it by your workload or by your internal load. And then typically running programs are going to be designed to gradually increase running loads because there's a concern that doing too much too soon, too fast is going to put a runner at an increased risk of sustaining an injury. Currently, though, it seems that most running programs are going to look at the week-to-week changes based off of external loads, so time or distance. And so again, that's failing to take into consideration variations in intensity between these running sessions. There have been a couple studies, one in adults and one in adolescents, that looked at week-to-week changes and found that there was a significantly lower change in running load when you only looked at distance or time compared to when you looked at distance and time and incorporated the intensity with it as well. And so solely relying on external loads may actually underestimate the loads that are being experienced by runners. Now, the study that was done in adolescents was only over a 2-week period, and the first week was designed to be a low volume running week, and the second week was a high volume running week. And so we were interested to see if there were similar differences over a longer duration. And so we compared weekly changes in both external loads and workloads during an entire cross-country season. So again, we used our high school runners during the fall 2020. And each of them had that GPS watch. So we were able to go in and pull out the time, distance, and number of steps per run. And these were measures that we used for our external loads. And then we also asked them to do that self-reporting of their SRPE, with 1 being very easy and 10 being maximal effort. And then we could tie those runs back together for days that they recorded a run with the watch and days that they reported their SRPE from their running log. We then took each of our external loads and multiplied it by their SRPE to get a workload measure for each of those external loads. And then ultimately our purpose was to look at weekly progression or week-to-week changes for external loads and workloads throughout the entire season. So we collected 8 weeks of data, which then resulted in 7 2-week cycles for each runner. And we took the average of those 7-week cycles for each runner to get their season average weekly progression for all of our loads. We then used paired t-tests to compare external loads to their respective workloads to see if there were differences in weekly progression between external loads and workloads. So taking a look at our results here, on the x-axis are going to be our load variables, and on the y-axis is going to be the average change or the week-to-week change throughout the season. Starting with our external loads, time, distance, and number of steps, we found that on average during the season, there's about a 0% change. So from week to week, they remained relatively consistent when we're looking at the duration and the distance they ran. However, when we included intensity with these variables, we found that there's about a 5% change for our workload variables on average during the season. And so they were 5% greater than what we saw with just the external loads alone. So our results are similar to what previous studies have found, in that progression in external loads is significantly less than progression measured by workloads. And so this suggests that workload is going to provide us a more comprehensive approach to monitoring the running loads that our runners experience. If we only rely on external loads, we might be underestimating the loads they are actually experiencing. And it's really simple to incorporate a running intensity by just having them report on a scale of 1 to 10 how hard the run was, so that we can get a little more comprehensive approach to measuring the workload. But then ultimately, more research is needed to understand what's the importance of workload or progression in workload as it relates to injuries. So we're going to need large cohorts to follow longitudinally and see, is there a threshold that runners should remain below when they're increasing their workload to reduce the risk of sustaining an injury. So in conclusion, progression in external loads was found to be significantly lower than progression as measured by workloads, which further supports the notion that external loads alone may underestimate the stresses applied to runners. And so it may be more appropriate to incorporate a running intensity such as RPE to get a more comprehensive approach to analyzing running loads. Thanks for your attention.
All right, thank you very much, Micah. Now we're going to move into the Q&A session. So the first question is from Tishya to Morgan. Why did you scale force using muscle volume rather than PCSA or some measure of area?
Thanks for the question. That's a great question. So we used muscle volume because that was what was readily available in literature to be correlated with the body weight. However, to note, we scaled the effective volume of the muscles. So we converted that to PCSA using the scaled optimal fiber length. So ultimately we took muscle to PCSA based on the optimal fiber length.
Awesome. And then there's another question from Jordan Sturdy for you, Morgan. Great job. Given the underestimation of joint moment after applying the strength scaling, did you look into whether the muscle moment arms in the model scaled in the same proportion relative to the generic model as the segment lengths?
Yeah, so this is a great point. We didn't explore that. So we didn't look at that, but that's definitely something worth looking into. However, pediatric moment arm is not readily available literature-wise, so it'd be important to get a new data set for that in order to understand how the moment arm is expected to change with bone length as they grow.
Awesome, thank you. And then Matthew, here's one for you from Mike Hasher. Very interesting study. Have you considered indexing the function of muscle groups, flexors, extensors to supplement your findings at the joint level? If so, anything interesting to report there? Thank you.
Yeah, thanks for the question. We have not considered that yet, but I think that would be very interesting. We were kind of drawn to the joint functional index because it simplified a number of variables into something, maybe tangible, and now we're trying to open it back up and look at it from a more complex perspective, particularly as far as maybe why the ankles, they're unable to maintain the ankles spring function, and then what's driving those individual differences. So I think that certainly could be a great place to start to look into that. Thank you.
Awesome, thank you. Micah, I've got a question for you, mostly on your first presentation. So you said that these were high school students. And I'm not a runner. I don't read running literature, so this is probably a dumb question, but I'm going to ask it anyways. Do you feel that adolescent or younger runners self-report their running intensities differently than older runners or more experienced runners by any chance?
Yeah, that's a good question. We've had some conversations about that. We don't necessarily have the answer right now, but I mean, the average running experience for these runners was about 10 years. So most of them had been running for a while. So I think they had a pretty good feel of, what a high intense run is and low intense run. But yeah, there certainly could be differences in how, an adolescent kind of has this subjective measure of intensity compared to adult.
So then to follow up with that, would you consider maybe using experience as a runner as a covariate? So if you have someone who just started running versus someone who, is technically an expert with their 10 years of running, do you think that would influence your outcomes at all?
Yeah, so that's certainly something that we can look into. That's a great recommendation. Something that we have looked into though is, so we also asked them to report what type of run it was. And so it could have been an easy run, just a typical run, or like a fast speed workout. And we did find that their reported perceived exertions were different among those, whereas the faster they were going, the harder they were reporting the intensity.
Okay, very cool.
Kind of to follow up on that, I'd be curious to see how much correlation there is between if it's a coach dictating it's supposed to be this intensity run, like are the athletes going to say, oh yeah, I was in that, or as a former runner at a few different levels, like sometimes your actual exertion level doesn't match up with the run of the day for variability of factors. So it'd be interesting how much their self-reported is influenced by what it was supposed to be.
Yeah, I completely agree. And we wish that we would have got what their run was supposed to be and see what they would have reported, but hopefully we can start capturing that in the future.
That would be cool.
Cool.
All right.
Yeah, if there's no other questions, I guess we can conclude this session. As someone who research revolves around pediatric biomechanics, it was really interesting or exciting to organize this session and hear everyone's talks. And if anyone is interested in continuing these discussions, we will be moving into spatial chat room S3 Aristotle. So enjoy the rest of the conference, everyone.
Hey, I feel like that was a success. Nice job.
Yeah, you too. Yeah, definitely did without Erin, even if it would have been fun to have her here too.
Yep.
Mm-hmm.
Cool. So do we need to download the chat? I know that most of our questions were answered. I saw that in another session where they took the chat and